Hi, good morning. It's a privilege to get to speak today. So what I hope to do in my short presentation is present a few theoretical ideas, questions, tensions that I see of relevance to our panel's organizing theme of conceptualizing gay men's health. So I see this small contribution to the panel as an attempt to continue some of the critical dialogue that has been part of the summit in recent years, including Alana's keynote address last year, which Warren mentioned. And in doing so, I hope to build and not reproduce some of. And here's Alana right here. I'm just giving a shout out to you. That was timed. And so my hope is that we can build on some of the critical foundational work that was presented last year, and I've seen bubble up in some other presentations and conversations at the summit so far this year, and start to raise some questions around this organizing theme we have of conceptualizing gay men's health. So I'm starting with a basic argument to organize some of my introductory remarks. That is, health disparities among gay men are not the result of discrete singular factors, but rather the outcome of complex intersecting relations of power, structure, identity, experience, history, and social location. As such, in conceptualizing the field of gay men's health, the challenge is to look beyond singular unitary categories of analysis so as to more accurately map and conceptualize health determinants across diverse, heterogeneous populations of gay men. So what factors of social location, identity, and experience matter most in specific subfields of gay men's health research, policy, and practice is an open empirical question. And we've seen this issue also kind of bubble up in conversations so far. So this is a recognition of the inability to determine a priori what key structural intersections, what key identities and experiences matter. And that's an open empirical question and an open question for discussion. So the paradigm of intersectionality may help to foster critical thinking when reflecting on how the field of gay men's health is conceptualized. What intersections matter, how are categories conceptualized and used, etc. So this recognition demands that we draw attention to gay oppression alongside other intersecting systems of oppression as complex determinants of gay men's health. So as I said, I'm not going to reproduce for time reasons and for brevity an entire comprehensive discussion of intersectionality, but a few key tensions that I see germane to the organizing panel's theme I'll be highlighting. So intersectionality is concerned with bringing about a conceptual shift with respects to how researchers, public health professionals, and policy actors understand social categories, their relationships, and intersections. It requires a consideration of the complex relationship between mutually constituting factors of social identity and structural disadvantage so as to more accurately map and conceptualize health determinants. Theories of intersectionality, I'd argue, offer important challenges for HIV and AIDS researchers, social theorists, activists, and policy actors when they seek to conceptualize categories and examine systems of inequity. Intersectionality must not be reified. It's not a thing out there to discover, but rather a lens that we can use to help make sense of complexity and difference in the everyday world. Researchers of intersectionality work to critically explore intersections of multiple axes of oppression, and I'll be talking about that a little bit as I try to bring up some questions that might be of interest when we're seeking to conceptualize gay men's health. So a limited amount of scholarship in this interdisciplinary field has explicitly foregrounded issues of sexuality and HIV status among gay, bisexual, and other men who have sex with men. So, for example, in a recent critical review of intersectional theorizing, Hinman notes the conceptual complexity of dealing with questions of intersectionality. Quote, within LGBTQ political mobilization, in-group marginalization does not fall neatly along lines of race, ethnicity, or gender. through intersectionality has undertaken the important and significant task of shedding light on these imbalances. Beyond descriptive traits lie complex issues of desire, self-affirmation, in-group contestation, and individual and collective expectations, all of which coalesce to determine not only what people, but also which practices and which political interests comprise the group. The torturous history of signification offers a powerful testament to the agonism, compromise, and complexity that characterize the discourse on LGBTQ sexuality. So I'd argue we've begun to see a mainstreaming not only of models such as minority stress, which Alain Meyer highlighted yesterday, but of intersectionality into the LGBT health agenda. And so just as we use this Institute of Health diagram in our opening talk, we can return to it briefly to see that intersectionality, alongside other models, has begun to enter a mainstream around questions of sexuality and LGBT questions. Now, while I think that this is truly exciting, I would caution that the operationalization of intersectionality by the Institute of Medicine as a perspective that examines, quote, an individual's multiple identities and the ways in which they interact, risks obfuscating important discussions of power, history, and social structure, and recasting the discussion of LGBT health as one of identity politics, removed from considerations of structural disadvantage. So I would argue that while subjective lived experiences of inequity must be accounted for, one must not lose sight of the complex structural conditions and power asymmetries that help to produce health disparities. So basically, the simple point here would be that in our discussion of intersecting identities, we need to keep structure in view. That if we recast this discussion of one only of identity politics and don't account for power, history, and the broad structural determinants of health, we risk really losing the powerful political impetus and commitments to social justice that intersectionality would demand. I'm just going to now quickly note a few things that might be helpful in our discussion when we're talking about how to conceptualize gay men's health. And so just briefly going over a few tools. So one question would be, how do we use categories? Intersectionality demands that we think not only about what categories we use, but how to conceptualize the coherence or durability of categories. So one question might be, what categories? So for example, thinking about how we use categories of most at-risk populations in policy strategies, e.g. what do groups like gay, MSM, black MSM reveal, or race, is really important in this field of inquiry. As Hinman argues, we must not fractionalize social groups by, quote, treating formally broad descriptive categories such as woman or African American as smaller, internally coherent empirical units. So this would be one question that we might think about when conceptualizing gay men's health, which is kind of what categories. The other is almost a broader question about this McCall typology helps to elucidate, which is, how we consider the durability of categories or the coherence. So McCall highlights we must consider how to construct and use categories. So this would allow discussions of a complete rejection of categories of sexual orientation. So on one extreme, we might discuss that when we use particular categories in gay men's health, that's really dangerous and erases the complexity and in-group heterogeneity of particular groups. And on the other, the provisional or strategic use of categories while recognizing their limitations. And so the argument would extend that different kinds of substantive knowledge are produced by different methodologies and conceptualizations, and that maybe this provisional category approach, the recognition that categories have some use when we're constructing and doing work in gay men's health. So I just have a little bit of time left. So what kinds of intersections would be another key question, and we'll see this come up in the panelists that follow as they draw attention to particular subfields. So kind of intersections might be things like identities of an individual, sets of individuals or a social group, categories of difference, processes of differentiation, systems of domination. And I think hopefully as we have our discussion, we'll be able to, I think there's some utility to analytically stratifying how we use these different kinds of intersections and what we're really getting at. So as a kind of summary of some of the utility, this is just a kind of working model to try to summarize some of what intersectionality might offer, which would be always, I cautioned against the danger of only making this about individual subjective identity. And so on one hand, we're talking always about systems of power and domination, intersecting interdependent systems of systemic oppression. And on the other, always talking about individuals, social groups, and lived actualities, lived realities in the everyday world. So those simultaneous co-constituting intersections and interactions of identity and social difference. So it's with this kind of like broad schematic, and for me as part of an intellectual exercise, which can help us map some really basic questions which I think help to frame a discussion of gay men's health. So in moving from this kind of broad schematic, we have a few basic questions for me that are important. So what structural issues impact gay men's health? Racism, colonialism, we haven't really talked about capitalism yet, sexism, ableism, heterosexism. What interactions of identity and social location matter for gay men's health? A number of these have come up in discussion. And who are we missing, excluding, or erasing in our framing of gay men's health? And so the panelists that follow, and it was really exciting to talk through these issues with my co-presenters, because for me a lot of these tensions kind of bubble up and reveal themselves in the really important work that they're all doing. And so, broadly speaking, I'd say these are a few of the major tensions we'll see, and you'll probably find other connections that we'll bring to discussion. So what categories and what consequences, what kinds of intersections really matter when we're doing this work, and what kinds of methods. We have had a bit of a discussion of methods so far, but what kinds of methods are used in our work. Great, thanks very much.
Thanks, Daniel.